Today on the podcast, we're going to be talking about some awkward and maybe tough conversations that we have with patients frequently. Last week, we talked about what not to say, and today we're going to focus on what we can say and how to approach some of these conversations a little bit differently. Stay tuned. Welcome back to the Grow RDH podcast. My name is Katie. I'm a dental hygienist from South Dakota, and I am happy to have you back. If you're a repeat listener, thank you so much. If you are a new listener, we talk all about dental hygiene on the podcast, and it's just a casual conversation to give you some ideas to grow in your career. Today's topic is having difficult conversations. Again, like I said, last week, we talked a lot about things we should avoid saying, some words and phrases that we maybe shouldn't say or try to get away from. And today we're going to kind of sort of switch that, and we're going to talk about things that we can say or maybe how to approach difficult conversations. I broke this episode up into 3 different themes, and these themes that we're going to talk about this week include procedure hesitancy, patient compliance, and then financial barriers. The first one we're going to talk about is procedure hesitancy. And there might be a lot of reasons for procedure hesitancy, but this could be getting an injection with a needle. It could stem back to dental anxiety about specific procedures that maybe have hurt in the past, like SRP. And a lot of the times, patients push back on us from hesitancy for a number of different reasons. Those reasons can include what I just said, or it might even be that the patients don't understand the recommendations. A lot of the times when we get informed consent, yes, we're supposed to educate them, but if they don't understand the nitty-gritty details, they can be very hesitant. So there's a couple different examples that I can give when we're talking about procedure hesitancy. The first example I'm going to give, I actually use this example a lot when I teach ethics and we talk about trauma-informed care. But one of the examples, I work in a Department of Correction setting and we work with offenders, but my patient had a severe drug history and I was going to give anesthetic, and I had already told him that we were going to numb him up. So he knew it was coming. He knew like he was going to get numb in some way. But immediately, as soon as he saw the needle, he had a trauma response and it turned into an anxiety attack. Later, I learned that he had IV drug use history and he was having a traumatic response to his addiction. And it brought up a lot of feelings and a lot of memories of times when he was using a needle. And that is a very over-exaggerated response, but it's a response that you might get. And I think what this story does is it shows a picture of reasons that we don't understand. And it goes back to, we have no idea what the patient is dealing with or has dealt with in the past. And sometimes procedure hesitancy just takes a little bit of talking to really understand why they don't want to do something. Really diving deep into those details can really improve your patient acceptance for treatment rate, and it really does make a difference as you learn and grow in that relationship with the patient to understand their inner motivation. We had this patient leave the office, and I sat out in the hallway with him and we talked through some stuff. While we were in the hallway, we're right across the hall from mental health, and a provider was over there. We talked through it with the provider, and we actually got the patient back in the chair, and we were to do SRP with topical anesthetic only. And it took a very long time. We worked on like 2 to 3 teeth at a time. And it was very thick, heavy subgingival calculus, very tenacious, and it took some time. But there are always ways that we can work around hesitancy. I always like to use the example of x-rays as well. I know some patients are very against radiation, and that didn't help when Dr. Oz came out with his big to-do over x-rays. On this Dr. Oz episode, he put a whole thing out about how dangerous dental radiation is and how patients should talk to their providers about the frequency. And while I think a lot of us in the dental industry felt very like, oh my goodness, this created a whole wave of patients that were asking these questions. And while I understand the frustration, I want to offer this as an opportunity for patient education and growth. I totally support patients asking questions about their care. And I love the fact that patients are interested and want to be healthy. So at its most underlying, at its most basic awareness is that it's okay that patients want to know. And I think how we approach that is also an opportunity for learning. I do think that sometimes dental offices choose radiation frequency based on insurance reimbursement. And this should not be happening. Radiation frequency should be based on the patient's caries rate. If the patient has a really high caries rate, maybe they score high on the camera, yes, their frequency should be increased. But if a patient has a very low caries rate and they do not show caries and they have a very long history of not experiencing caries in their mouth, their frequency should be extended. So use this as an opportunity to discuss their caries rate. If they're asking questions about how frequent they should get radiation, you can turn that into a learning process about caries and the spread of caries and the causes of caries and how their individual caries rate should help you choose the frequency of how often patients get radiographs. If you have a high camera, you can show them their camera score. Say, look at this risk assessment we did. This risk assessment tells us that you are very highly likely to have caries in the future. Radiographs help us detect those caries at a very early stage. And if we can catch it in the enamel, that is going to prevent that tooth from being further infected. So approach it from an educational and research-based standpoint, and they probably aren't going to have much to argue with. Patients a lot of the times like guidelines as well. You can show them the guidelines, you can show them the research if they care or if they're asking. We talked about in our Enneagram series, Enneagram 5s love research and they're very intellectual and they want to understand. So show the guidelines, show the camera score, show all of those things that support your decision. The more support that you can show them, the better they are to accept it. The next theme that we're going to talk about in having conversations with patients is patient compliance. Patient compliance is obviously a huge part of our job as hygienists. This is because we see them once every 3 months up to once every 6 months. And all the rest of the time, that 2 months and 30 days, we are relying on the patient for compliance and good home care. Having conversations about compliance can be tricky and can be hard, especially if the patient is not holding up their end of the deal. And this is where I am going to recommend going all the way back to dental hygiene school and pulling out your mirror. Using a mirror during the appointment, I give them the mirror at the very beginning. And I ask them if they're interested or if they want to watch me do the procedures that I'm doing. And again, I work with offenders and they are the best patients ever. I absolutely love my patients. I love my job. And they are so interested. I've had so many aha moments with patients when they're watching and seeing the plaque. And then when I go with the Explorer and I remove the plaque and I show them, their eyes are just like, but I just brushed this morning. And I said, that's great. It's good to know that because what that tells me is that if you brushed this morning, it's not your frequency of brushing, it's your technique. So let's look at how you're brushing and let's adjust based on where the bristles are getting. And then same thing, I have them hold the mirror and I have them brush, and they can angle themselves and see how to get the bristles up in those areas. So I know that sometimes we get away from the things that we used to do in school, but I want to 100% recommend using a mirror. It's hard to argue when you're showing a patient something that they can actually see. It's not your word against they can't see it. It's their word against what they're looking at in the mirror. And I just, again, I have so many good aha moments with them and good conversations when they actually see the plaque. Same thing with bleeding. A lot of the times they'll be, perio maintenance. I see them every 3 to 6 months. And they will have specific areas that show redness, that show inflammation. They can see that in the hand mirror. And I just had a patient this morning, that most everywhere looked beautiful. It looked pink and firm and healthy. But there was one area between his canine and his premolar that the gum was really red and puffy. And I just grabbed the hand mirror out. I showed him, I said, can you see the color difference between this area and this area? And he was like, yeah, wow, that's a really big difference. He's like, I guess I don't notice that when I look in the mirror when I'm brushing my teeth. And I said, yeah, it's a simple fix. Just, really make sure you're pulling that lid back when you look in the mirror. Really make sure that that is an area you're getting. And, that's a common area when you're crossing over. It's kind of on the borders. And I told him that's a common area to miss. And he was just astounded and mind blown that he could really see the difference. And he said, I'm going to watch this area. And I said, great. But again, patient compliance, I, number one, recommend use a mirror. For patient compliance, my second recommendation is to, again, offer options. I know I've talked about this a lot when I talk about motivational interviewing, but you're laying the foundation of giving options at your very first appointment, and you can follow up on this every single appointment. And I'm going to go back to what I've said in a past video about MI, is that when you give them options, you're always ending the conversation by, okay, you've chose to, use this electric toothbrush. That's what we're going to work on for the next 3 to 6 months. And then when you come back, we're going to evaluate how well that electric toothbrush is working, or how well that change is working, whatever change they're going to make. That's the foundation to this patient compliance recommendation. Because you've already laid that foundation, at this appointment, you're going to look back on your notes, say, this is what we talked about, and you're going to ask right away the first thing, because that tells them that you remembered. So I will say, how was it going with the electric toothbrush? Last time we talked about making this change, and I'm really excited to see the results. Have you noticed a difference? That will give them the opportunity to kind of say, yeah, I've been using it, or no, I haven't, or yeah, I've noticed increased bleeding, decreased bleeding. That way you can kind of get a feel for how compliant they've been even before you look in their mouth. After that, then you are going to go in and see if it made a difference. Compare the perio charts and say, I don't know if we're just not using it correctly, or maybe the frequency is a little off, but compared to last time, I'm seeing an increase in plaque in this area. That opens the door to talk about other changes you can make. And if you laid the foundation well, you can say, last time we talked about maybe a water flosser instead of electric toothbrush. Are you interested in maybe trying the water flosser this time, or trying to, brush this area a little more this time? It allows for change and adaptation to the patient's compliance. That way, it's not just are you brushing twice a day? Yes, I am, or no, I'm not. It's more of a conversation, and it's a discussion about what the patient's actually doing and what you're seeing in the mouth, and how those two things tie together. We're all about open conversation because that helps us learn more about the patient's wants and needs and what they're capable of. The third area that we're going to talk about is finances. And finances is always hard. This ties a lot into insurance reimbursement. And we all know that insurance reimbursement for dental insurance is a flawed system. And that is a whole episode, that is a whole month of issues surrounding dental insurance, and I don't want to get into dental insurance, but I have to touch on it a little bit because that is the number one argument against them not doing something. My insurance doesn't cover it. So how we get around talking about that is making sure that we are tying our procedures to the actual conditions present. If they understand that the procedure that you're recommending treats a condition that they have, SRP treats perio, you can present it as something that they obviously need, right? A lot of the times I like to compare it to medical procedures, right? If you had an infected bed sore, the size of your palm, which is the size of perio, if you had an infected bed sore and, it was inflamed and it has pus in it, Would you, if the doctor recommended, this treatment, they were going to debride the wound for you, would you do it no matter what, if insurance covered it or not? And I know that sounds extreme. Sometimes that might come off as a little bit of tough love, but again, it's essential to tie it to the condition. If they understand that it's a gum infection, and they understand how big and wide that infection really is, you are better able to get them to understand how important the treatment is. Same thing for a prophy. I know it's not as serious, but if they have gingivitis, maybe they have mild gingivitis, and they understand that if they don't get it, it could lead into perio, they may better accept it. Now, sometimes that's hard. We don't have to deal with that a lot because most insurances cover prophies. It's the other procedures that we don't necessarily always get full coverage on that patients really seem to push back. So that's the insurance talk, I guess, and I'm not going to dive deeper into that. It's just separating it out from the insurance. This is a condition. This is a medical condition. And this is the treatment for the condition. Second thing is just finances in general. Finances are very hard, especially in this economy. We are all struggling, and showing empathy and showing the patient the value in what they get, taking time. There's nothing worse. The number one complaint most patients have is when you rush through a prophy, you spend 10 minutes, polish, ultrasonic, flush, done. There's no value in that. So I want to just maybe put us in check just a little bit to say the more thorough you are and the more value you provide, your patient is going to understand that value. And that starts from the moment that they sit in your chair. A lot of the times, patients have true emotional responses to money. And that's because there's a lot of anxiety and uncertainty about the economy and about income and about paying bills. If they're making a decision between having to pay their electric bill that month or having to pay for SRP, they're probably going to choose their electric bill. So making sure to work with patients on phasing treatment out, making it approachable, making it something that they can feasibly do is a conversation that is under our scope. Some offices really put that responsibility on a patient care coordinator or a treatment plan coordinator, whatever your office role is. I don't think that we should step back from that completely, because what you have as the hygienist, even if you have a care coordinator, what you have as the hygienist is the educational knowledge to teach the patient about the value of the procedure, the medical value of the procedure. The patient care coordinator is going to help them with options of how to afford it, but we have the knowledge of why it's important and why it's valuable to them. I want to touch a little bit on adjuncts as well. I know some of the more corporate offices and DSOs really do upsell. And I think that that is a huge disservice to sell adjunct procedures that patients don't need. And most of the time, it's really based on the patient's immune system and the patient's ability to fight it off on their own. If you're recommending an adjunctive antimicrobial for every patient in a stage 3, that's not really evidence-based. And adjunctive antimicrobials can be very expensive. So offering that as an option alongside your SRP and not just a bundle of this is your SRP can go a long way to giving a patient financial stability or financial options. So we want to make sure that the adjuncts we're recommending are specifically unique to that patient's needs. So essentially, to summarize the financial piece, we really just want to make sure that we are selling health and we are selling procedures that are necessary to treat a condition. If we can do that before the cost even comes up, we are laying a foundation of understanding of value, not cost. And that is it for today. That is the episode. Remember that our words matter and we do not have to be perfect. We can each individually have our own ways to do this, but we do need to be kind and we do need to be consistent. And because I love alliteration, we also need to be confident. We can go into these conversations practiced. And the more you practice it, the more confident you're going to get doing it. As we've talked about, the goal isn't to win, or the goal isn't just treatment plan acceptance. That's not the be all end all goal. The goal is to foster the relationship. And if we can foster the relationship in the early stages, treatment plan acceptance comes after. So if you can build that relationship while maintaining your clinical integrity, you are going to be far ahead in the race towards treatment plan acceptance. Let me know what you think in the comments. Give me some ideas. If you have ideas or things that you've used for patient conversations in the past, educational tools, I would love to hear them. Share them down below, share with the community. And if you like this content, please share with another hygienist you think might value this. We are going to be finishing out July with another episode about communication and conversation. I hope you enjoyed it. Thank you for being here, and I will see you on the next one.